Hi. First off, I want to just say thank you for the invitation to present some of my research today. My name is Daniel Weiss, and I'm currently a senior researcher at the University of Science and Technology and the Hunt Research Centre, as well as the Nordland Research Institute in northern Norway. My background is mostly in public health and the sociology of health, and today I've been asked to present for you all a bit of my research on the diffusion of innovative technologies as a potential fundamental cause of social inequalities in health. So the paper I've been asked to present for you guys today is this paper here, published in 2020, entitled "The Diffusion of Innovative Diabetes Technologies as a Fundamental Cause of Social Inequalities in Health" in the Nordland Health Study in Norway. I also want to present real quick for you guys today some conclusions from the results of two other papers published by a colleague by the name of Emil Oversveen. The reason I want to also include those is because he's also done a little bit of research on a similar topic, looking at diabetes and social inequalities in health. The big difference here is that Emil's work is primarily qualitative, and the results that I'm going to be presenting for you all from my paper today, is purely quantitative. So they complement each other well, so hopefully it gives us a little bit better overview of the topic in general. So going over to my paper, the aim of this paper was to investigate whether innovative health technologies and associated improvements in disease management diffuse unequally by socioeconomic status, giving rise to inequalities that are stronger when technologies are new. We did this by first measuring the probability of adopting a new diabetes technology based on education and income, by investigating use patterns of diabetes technologies based on education and income, and investigating whether potential variations in socioeconomic status-based adoption and diffusion have an effect on inequalities in relevant health outcomes. I just want to note that the second aim here differs from the first, in that it's not just concerned with whether or not a technology is accessed for use, but whether there exists significant variations in interaction between adopter and technology. In other words, the ways in which the technology is used by the user to exploit its potential benefits. Okay, so a little bit about the methods. We use diabetes as a case. There's a few different reasons for that. First off, we had good data in the Hunt survey across the different panels, looking at the use of different diabetes technologies, so that made it a good candidate. Also, international research has documented increased prevalence, poorer regulation and control, and increased mortality for low SES groups when it comes to diabetes. This is also even in nations with strong universal healthcare systems. Furthermore, effective management and control of diabetes is very dependent on active self-management and the use of technologies, making it also a good candidate for us. Real quick about the Norwegian context. Norwegian healthcare is generally characterized by predominantly public-funded universal system of coverage, where only 15% is funded through out-of-pocket payments. Inpatient care at public hospitals in Norway is free. GPs generally act as gatekeepers for specialists and elective services, and specialists are ultimately responsible for prescribing the use of state insurance-covered technologies, which is relevant for this study. When it comes to the data that we used data from the Hunt survey. The Hunt survey is a large population survey with various questionnaires that have gone out to a large portion of it's gone out to the entire population within a certain sector of central Norway. The Hunt study was started in the 1980s, and since then they've had 4 cohort panels. In this study, we used just the first 3 cohort panels because the data for the 4th cohort panel wasn't ready for us to use when we underwent this analysis. But the first panel was from 1984 to 86 with 77,000 participants. The second was from 1995 to 97 with 65,000 participants, and the third from 2006 to 2008 with 50,000 participants, which gave us a total of 166,000 observations, available from 97,000 individuals who have answered either panel 1, 2, or 3. Education and income data were used as measures of socioeconomic status and merged from national registry data. Within the Hunt study, there are various different surveys and questionnaires in addition to the general questionnaire, and one of those is a diabetes questionnaire, which we used in this study. Here are the variables that we have from the Hunt studies that we've used in this particular study. So in Hunt 1, 2, and 3, we have different measures for measuring blood glucose, blood sugar levels at home. In Hunt 1, 2, and 3, we also have different measures of injecting insulin at home using different devices. In Hunt 2 and Hunt 3, we have the frequency of blood glucose measurements weekly. And across all Hunt surveys, we also have the length of disease history, which we generally use as a proxy for measuring severity of illness. Here we see a timeline of the availability of the different technologies that are used in this study, and you can see that most of them are grouped around the time of the first Hunt study, some before and some during and some after. Here we see those the general different types of technologies that we have available in each Hunt study, and whether or not they're classified as old or new in each of the studies. So the only technology classified as new in the Hunt 1 study was measuring blood sugar at home using strips. In Hunt 2, we have 2 new technologies, measuring blood sugar at home using a digital measuring tool, and injecting insulin at home using a pen. By the time we have the Hunt 3 study, all the technologies are considered old, which also limited our analyses to a certain extent. Okay, here we have some of the results. First off, we can look at diabetes prevalence, which generally increased in total over the time period of the 3 surveys, as you can see. And here you can see that, generally speaking, low socioeconomic status groups represent a larger portion of the sample with diabetes across all 3 time periods. However, although the low SES groups represented the largest share of individuals with diabetes across the different panels, the data seems to indicate also that middle-educated and high-income groups represented the largest share of the total increase of diabetes over time. So we see that there's both an increase of diabetes over time and a larger portion of the sample with lower socioeconomic status that's represented in the sample with diabetes. However, as the prevalence of diabetes increases, that increase is generally overrepresented by groups of middle educated and high income. If we look at the next table, interestingly, the next table shows HbA1c levels over time, which tend to decrease from Hunt 1 to Hunt 3, and together with the previous data suggesting increases in total prevalence of diabetes, but an improvement in overall diabetes management over time. It can also be noted now that we consider differences in HbA1c levels greater than 0.5 as clinically significant in this study. And you can see here that Hunt 1 showed the only significant differences in HbA1c levels based on socioeconomic status, generally favoring those with higher socioeconomic status. Okay, moving forward, our results, the results of the analysis generally show that social inequalities in the use of diabetes technologies exist regardless of technology type or measure of SES, and are particularly strong when technologies are new. So in the first table here, you see associations between education level and income and the use of diabetes technologies. And we see that we have significant results here for in regards to socioeconomic status when it comes to new glucose technology in Hunt 1, which was the measuring of glucose at home using strips. We also have significant results for old insulin technologies in Hunt 1, which was injecting at home using a syringe. And we also have significant results based on socioeconomic status in the Hunt 2 study for new insulin technology, which was injecting insulin at home using a pen. So this essentially just seems to reinforce the idea that adoption of newer technologies is generally greater among high socioeconomic status groups. Interestingly, in Hunt 3, where all technologies are considered old, there's no significant results after controlling for age, gender, and length of illness, suggesting that even though the numbers present the reappearance of unequal distribution by socioeconomic status, technology adoption has possibly reached a level of close to full diffusion by the time we reach Hunt 3. Additionally, you can see that available data from Hunt 2 and Hunt 3 suggests that higher SES groups measure blood glucose more regularly than low SES groups, regardless of the technology type. However, the differences appear greater when innovative technologies are available. So here we see the number of times per week individuals on average measure blood glucose levels at home in Hunt 2 and Hunt 3, and we see that for Hunt 2 there's a socioeconomic gradient that seems quite strong, and in Hunt 2 we have the availability of new technologies. Okay, furthermore, looking at the results here, our analyses of a cohort from following a single cohort from Hunt 1 to Hunt 2 suggest that during that period between Hunt 1 and Hunt 2, the adoption of insulin injection technologies was unequally distributed by socioeconomic status, favoring individuals with high education and income. However, after controlling for age, gender, and duration of illness, inequalities in adoption become statistically non-significant. So unfortunately, the non-significant results are likely a result of a small sample size. We didn't have a whole lot of individuals in the data set to analyze as a single cohort here. So the N value here, total number of individuals, was 190. What would be really interesting would be to be able to run a similar analysis with a larger sample. So if anybody knows of a data set that can be used for that, please let me know. Here we do see, in any case, what looks like a relatively strong socioeconomic gradient when it comes to new insulin technologies. We see that the odds for high educated and high income groups is quite a bit higher than it is for low and medium educated and low income groups. However, as I said, the results were statistically insignificant based on our small sample size. Okay, I wanted to show you guys one more table here before we move on. This is a supplementary table from the paper, and it's the unadjusted values for number of adopters and non-adopters of diabetes technologies by socioeconomic status for the cohort that we followed from Hunt 1 to Hunt 2. And what's interesting here is we can see that generally speaking, when it comes to glucose technologies, we see a much higher total level of adoption, where close to 90% of the sample has adopted glucose technologies, whereas only 65% have adopted insulin technologies. We also see over here mean HbA1c levels for adopters and non-adopters of these technologies, and particularly for insulin technologies here, we can see that there's a pretty big difference between HbA1c levels for adopters versus non-adopters, where adopters of these insulin technologies seem to have pretty large benefits in regards to mean HbA1c levels. Okay, so over to conclusions. First off, generally speaking, more active engagement by high SES groups who often use technologies at a higher rate and frequency. This was particularly present for insulin injection technologies, which is possibly a result of the more rapid diffusion and adoption of glucose monitoring technologies witnessed in the study. Results also suggest that as education level increases, so too do the odds and rates of adoption, particularly when technologies are new, and that early adopter groups generally consist of individuals of high socioeconomic status. That gives us support for the diffusion of innovations theory, which we also use to underpin some of the theoretical perspectives in this study. So what are these inequalities a result of in accordance with our understanding of the results? Well, first, possibly preferential treatment for high socioeconomic status groups. Here, previous research has shown that clinicians often consider high SES patients to be more motivated and more capable of effectively utilizing more intense treatment regimes that utilize innovative technologies. So that's possibly an explanation for some of the inequalities we see. Also, it's possible that the differences in total diffusion between technology groups may be a result of glucose measurement innovations being more simple than insulin injection innovations for users over this time. So there's research that also supports this idea that adoption increases when technologies simplify treatment regimes. However, another alternative is that companies initially often offer these technologies free or at discounted prices, but charge for continued service and use. And also the state also financially supported some of these technologies, particularly monitoring devices. So that might also explain a certain element of both the rates of diffusion and the inequalities within those rates of diffusion across socioeconomic groups. It's important to highlight the fact that our results suggest that quality in adoption does not mean equality in use. So even if individuals have access to a particular technology, that doesn't necessarily mean that it is used in the same way based on socioeconomic status or that it necessarily has the same effect. And it's also unclear if the adoption of these technologies results in improved health outcomes, since we didn't necessarily see any significantly clear trends in regards to average HbA1c levels across groups and across that time period. Yeah, in regards to in regards to the equality of use, our results also suggest that patients of lower SES socioeconomic status may have received and used these devices for a period of time, but to a greater degree discontinued or reduced usage of the device. A finding also supported by research identifying relevant psychological and economic barriers. So that also might contribute to that difference in outcomes. Okay. We also discuss this idea of technology as a form of symbolic capital in the paper. Essentially, the idea here is that the early adoption of health innovations may afford users with specific benefits that can accumulate over extended periods, but which do not necessarily present as traditional markers of illness. An innovative insulin pen, for example, does not necessarily need to exhibit a significant impact on HbA1c levels for it to be a symbolic representation of the ideal patient or ideal user, which in the eyes of a clinician or other health-related personnel embodies a more worthwhile investment in additional resource allocation. The clinician in this case is not just a gatekeeper to additional services, but also an agent of change, facilitating the flow of innovative technologies to users and providing a link between clients and a resource system. So an actively engaged high SES patient is also likely to be rewarded in a sense with higher quality clinical interactions and a greater level of effective institutional resource allocation. This is a result of their display of masterfully managing both their illness and the innovative technologies largely symbolizing representations of modern medicine. Okay, real quick, I want to present a little bit of supportive research from the two papers by my colleague Emil Oversveen. In the first paper, he has collected interview data from users, diabetes patients, users of these different types of technologies, and he concluded by categorizing these users into three general user types. First off, active users typically emphasize the importance of information and control and use medical devices in order to micromanage their condition with the purpose of maximizing outcomes and well-being. High SES individuals generally tend to be a part of this group who lived up to the ideal of an engaged and technically competent user. Insulin pumps and glucose monitoring systems functioned as a means to assert and extend their already significant control over their diabetes self-management, as well as a symbolic resource, distinguishing them from other patients. Passive users, on the other hand, use the same technologies as the active users, but rather than using technologies as a source of increased control, passive users generally preferred delegating as many disease-related tasks onto the technological devices as possible, often describing self-managing as uncomfortable, difficult, and tiresome and personally dependent on these technologies. Antagonistic users, on the other hand, their practices and perceptions were characterized by conflicts, ruptures, and breakdowns in the human-technology relation. They would often misuse, sabotage, or harm their technologies, rejecting the devices entirely in favor of older and less technologically advanced setups. This often led to a combination of medicalization and powerlessness at the center of the relationship between technology and human when it comes to the antagonistic users. The second article here, Emil visited a diabetes clinic where he conducted interviews with staff as well as documented observation in closed staff meetings. And this research led to a categorization of three separate logics of selective empowering when it came to the staff deciding on who should be given the opportunity to use these various diabetes technologies, who should gain access to these different diabetes technologies that would be prescribed by the staff. Emil concludes that each form of logic can reproduce inequalities in different ways. So the logic of need tends to privilege those that best are able to communicate their needs. The logic of competence generally privileges those who are best at managing their illness. And the logic of compliance generally tends to privilege those who most adhere to implicit norms and expectations, those who are quote-unquote worthy. So his conclusion is that the clinic staff confronted a basic tension between the use value of medical technologies as remedies and their status as commodities produced for profit by commercial manufacturers. To a certain degree, staff were agents for commercial and market interests, as well as entrenched social norms, often disguised as purely medical decision-making processes. So, some real quick final thoughts here. Some thoughts for you all to consider as you move forward with this research and the implementation of the ideas from the project that you guys are working on. Are technologies designed and implemented to help individuals who need it most, or reinforce ideas of empowerment, creating resources for those who are already good at exploiting available resources for health, and generally transferring responsibilities for the goal of increased efficiency for health promotion and treatment to individuals, both as patients and non-patients. And second, traditional mechanisms of power and hierarchy are built into the everyday pathways driving technology and innovation, distribution, and implementation. This is something that's supported by the research that we have on the topic, and it begs the question: are we agents for reproducing these mechanisms or resisting them? And lastly, the research seems to support the idea that technologies are not neutral agents or resources for the common good. So thanks for allowing me to present some of my research today. I just want to point those who are interested to my dissertation if they're interested in reading more on the topic, where the title of my dissertation is the Pro-Innovation Paradox, Social Inequalities and Health in an Age of Technological Transformation, and here's a link for you all. So thanks again, and good luck with the project.